Hello, everyone, and good morning, and welcome to part four in our assertive field-based SUD services and treatment webinar series. Today's topic is data. We are super excited to present this webinar to you. Now, without further ado, we'd like to hand it off to our presenters, Robin Odendahl and Dr. Luke Bergman. Off to you.
Thank you so much. We'll spend just a couple of minutes, or maybe not even that much, introducing ourselves and then review the agenda and learning objectives, and then dig into the content. So my name is Luke Bergman. I am so pleased to be with you all. I see a few familiar names in the ticker indicating participants. So great to be among some of you familiar names even. I'm a principal at HMA. I've been in this role only for about 10 months now. Before coming to HMA, I was the behavioral health director for San Diego County for 7 years. So kind of grappling with some of these issues from a different vantage. And before being in San Diego, I worked in New York City. First at NYC Health and Hospitals, where I oversaw a lot of the behavioral health services there, including a lot of substance use disorder care, outpatient, inpatient, opioid treatment programs, et cetera. And then before that, I was the New York City Health Department for about 5 years, working in the Bureau of Alcohol and Drug Use. And in that capacity, which was, of course, like informed. Everything that we did at the health department in New York City was informed by a public health perspective, which I think is very important to the conversation at hand today. I did work that was about managing city contracts with treatment programs and managing efforts to kind of create a more robust recovery-oriented system of care in New York. A lot of the focus in my work there was on knitting together formal treatment with the really robust syringe service program network in New York City. So a lot of the work that I took to San Diego, kind of related to what we're talking about today, was informed by my experience working in public health, but on substance use care in New York City. So really happy to be here talking about this stuff with you all. I will hand it over to Robin.
Hi, everyone. So my name is Robin Odendahl, a principal with HMA, and love hearing all that experience of Luke. And I think together, what I bring to his experience is a background in data and how best to use data to make meaningful decisions and impact. So I bring to this work today about 15 years of experience working across the public and nonprofit sectors, including a community mental health center here in Colorado. But I've worked with local public health, local behavioral health, with a strong focus on using data to inform strategy, decision making, and implementation. This work includes working with some of you at the local level, as well as statewide with CDPH and DHCS. And my work spans, stakeholder engagement, needs assessments, social science, research and evaluation using both quantitative and qualitative methods. So a central thread across my work is really translating data into actionable strategies, which is relevant for today as we think about your work and how to use data for outreach and engagement. I've supported cross-sector partners in identifying and organizing multiple kinds of data across systems to surface patterns and gaps and use insights to shape efforts, initiatives, and strategies. So I'm really thrilled to be a part of this webinar with you all today and hope it can be helpful. With that, we can move to the next slide.
Great. So today's agenda will have us describing effective outreach and the role of data in outreach. We will provide something of an inventory of existing data sources. We'll review some considerations for outreach strategy and how to implement data-driven outreach within local environments, within local contexts. And then we'll consider some innovative strategies for bringing different types of data together, consistent with the aims of this initiative. So the learning objectives on the next slide are for participants to be able to describe the role of data in effective outreach to communities at risk of overdose, to create a process or processes for identifying, assessing, and applying data to outreach services. We'd like participants to be able to list at least 3 data sources that can inform their outreach strategy. And we'd like folks to be able to identify an immediate next step for at least one innovative approach to data sources, to interoperability, or to quality improvement. So let's begin by diving into describing effective outreach and the role of data. I want to do a little bit of throat clearing and just kind of note a bit about why we are all gathered here today, because I think that, the policy context is looming and important to note. Right? This is a thing that is getting the attention that it is to some extent because this is an initiative that is a requirement for counties per the Behavioral Health Services Act, right? This is an initiative that's noted within the FSP component of BHSA. I'm gathering most people on this call are very aware of that. And that the emphases described in policy guidance connected with BHSA and connected with the implementation planning effort in particular are for counties to proactively engage individuals living with substance use disorder and to offer low barrier access to medications for addiction treatment for people with opioid use disorder in particular. So counties are expected to identify populations at high risk. Those often will include people leaving carceral settings. Those will include people who are unstably housed or homeless. Those will include people with co-occurring disorders, right? These are populations, I think, very familiar to most of us in this field. So it's about identifying those populations and then doing targeted outreach to those folks, to the end of making MAT as accessible as possible. That it's the expectation at the state level that counties will engage in kind of one of 3, at least, I would say, one of 3 specific efforts toward the end of making MAT more accessible. And those 3 are data-informed targeted outreach. That's the topic of today's webinar. Also noted as among the kind of 3 options are mobile field-based programs and open access clinics. So again, just noting, the sort of policy imperative to do this work, I think, is unequivocal and clearly motivating for everybody. But I would say, under the banner, why this matters, the policy imperative is not really the thing that most matters about this work, right? To the people on this call and the people who will be most engaged in actually doing it. I think the context that's most important and that's most compelling, that will be most motivating for team members who engage in this, is the fact that huge numbers of people, wildly high percentages of people with diagnosable substance use disorder, never access care. Consistently, the estimates of people who would be diagnosable with substance use disorder who don't ever access care have traditionally been around 95%, right? So an incredibly high number. That estimate has a lot of ranginess. I've seen estimates of that number at around 75%, maybe just a tick or 2 beneath that. In any case, it's an enormous number. And the approach to substance use care and really the approach to nurturing healthier communities, therefore, cannot be that we just build it and expect folks to come at a volume or proportion consistent with the need. We have decades and decades and decades of evidence that doesn't happen. And so I think the terminology here is even really significant, right? We need to think about engaging people in care for substance use disorder and in sort of services generally to reduce harms associated with substance use, we need to think about that as work that is necessarily assertive, as stuff that we need to, to lean into kind of at a scale and scope and in ways that we haven't before in order to really kind of change the dynamic around service access. So on the next slide, are listed 8 components of what we think, kind of based on some references from CDC and SAMHSA, National Harm Reduction Coalition, et cetera, 8 components that we think are sort of key best practices in establishing effective outreach. In some, we can say, in pretty plain language, effective outreach is showing up consistently without judgment, offering practical tools to stay alive, to stay as well as possible, and really building trust. So people, when they are ready, can access help and the kind of help that they most want. I would say most important, kind of a through line through all of the 8 components listed here, really is that they are all about relational work. Outreach is not mechanical, it is not transactional, it's rooted in human empathic capacity. And it's effective really in proportion to the amount of energy and time and commitment that's devoted to building relationships. I want to sort of highlight the term consistent in the summary sentence on top, right? Outreach is not a thing that happens, and I think, again, most people on this call probably are aware. It's not a thing that happens quickly in almost any case. It's not a thing that happens based upon one interaction. It's a thing that almost always only happens as a result of consistent contact and the accrual of relational investment that is really genuine between people doing outreach and the people whom they are outreaching to. So to just sort of do a little description of some of the componentry here, right? When we're suggesting that we need to meet people where they are, right? That's become kind of a, it's such a frequently used notion in behavioral health work generally that I think it's almost lost its meaning in some context. We mean literally meeting people where they are. In this case, right? That doing assertive field-based work means going to the environment where people who are at risk of harms related to substance use are living, are staying, or are to be found. We need to meet them where they are emotionally. We need to meet them where they are in their relationship to harmful substance use. We need to not come into engagement with people we are trying to do outreach with an expectation that they need to demonstrate a commitment to sobriety, or that they need to demonstrate a even determination to address what would look clinically like addiction. We need to really focus on meeting them where they are physically and meeting them where they are in terms of their relationship to substance use and their relationship to their own risks of harm as a result of that. We need to do this work in ways that are culturally responsive. We need to pay attention to race, ethnicity, other demographic factors. We need to pay attention to language. We need to do this with a sense of, I would say, humility that isn't always, kind of like on brand with how local government acts with the people that it is aiming to serve. But I would say it's of paramount importance here. We need to approach folks with whom we are doing outreach work with a sense of deference, with a sense of humility, with a sense of openness and curiosity. And those are things that won't just happen if we do this work as we do everything from the vantage of local government and from the vantage of, what are enormous departments within county governments doing behavioral health work. So those are just some things that we would emphasize. Again, folks, you will get these slides, and I think it's important to, kind of as you're thinking about and building outreach capacity, to really be thinking about all 8 of these components. And happy to answer questions about thoughts about any specific of them. Maybe I'll just flag as we move to the next slide, that peer-led services are particularly effective in developing this kind of capacity. There are opportunities to do work led by certified peer support in California that are really, really, frankly, attractive from the return on investment perspective, and that have, just have oodles and oodles of evidence behind them at this point as the most effective ways to engage people. So let's zoom out a little bit and talk about the role of data in effective outreach, right? If outreach is the stuff that we've just described, how does data fit into that work? Just want to highlight two things at the outset, and then we'll talk in a little bit more detail about sort of some of the granularity of it. But I think just at the broadest level, two important things. One, data is really important to understanding the scale and scope of the issue that needs to be addressed. People in decision-making positions need to understand how many resources should be put towards something. Obviously, things like tracking overdose mortality has been incredibly important to moving resources in the direction of this kind of work, right? So that's probably the most obvious example. I think what's really important with respect to using data to kind of scale and scope things is to not get relaxed when we see epidemic curves pointing downward, as we're in the midst of I think, experiencing right now with opioid-related overdose deaths, right? We are seeing really significant downward movement. What we tend to see historically is upward movement with respect to other substance use epidemics in the context of a downward movement with respect to a particular kind of domain of substance use or substance use risk. So I think really important in moments like this, when we're thinking about the scale and scope of issues, that we stay really vigilant. Data is also, of course, incredibly important to guiding effective outreach efforts in peculiar or particular contexts. So on the next slide, we list kind of 6 important considerations in thinking about how to use data to inform particularly effective outreach. So we need to use data to identify who is at the highest risk. We need to focus on people and on populations where outreach can have the greatest impact. We need to be targeting where and when outreach happens in a data-informed way in order to manage resources and, again, in order to be most impactful in this work. We need to be using data and thinking about how we can best use data to inform what outreach delivers. If we are working with a population of people that is primarily methamphetamine using as opposed to primarily fentanyl using, if we are seeing potential xylazine use in a particular community, we need to be thinking differently about what the kind of content of outreach is in those contexts. Can use data really effectively to monitor engagement and to monitor access barriers ongoing. And that's very much related to how we can use data to evaluate what is working and what isn't working. And so we should be thinking about that in how we build data infrastructure. And then finally, data is really important to telling the overall story that's emerging and to efforts that we would make to make the work that we're doing sustainable. It's really important that we marry different kinds of data together to tell a really compelling story about the effectiveness of this work. On the next slide, we highlight work that's done in San Diego, and that's because I come from San Diego and everything in San Diego is just the best. No, I'm just kidding. It is, I think, an important reference, the work that was done in San Diego that I was somewhat involved in. There's maybe a San Diegan heart. Where I was behavioral health director, and I worked very closely with leadership in public health. And I think that's a really important aspect of this, that we married behavioral health and public health really as co-leads of an effort to establish this program we call OSAR, Overdose Surveillance and Response Program. There are just 2 things that I would want to emphasize about this. One is that I think it pretty elegantly illustrates how using things like surveillance data, so focusing on monitoring overdose data, and analyzing it can flag areas of kind of elevated risk, which results in deployment of community-based outreach and engagement efforts, and mitigating harm reductive and kind of treatment accessibility enhancing efforts. So the work that has been done in San Diego, I think, really beautifully reflects a kind of elegant relationship between high-level data and on-the-ground response. The other thing I would say about it, and we'll return to this over the course of the rest of the presentation, that I think is significant is that it doesn't reflect a kind of unilateral relationship between data and outreach doing its thing. Really important to the OSAR work is that the outreach then feeds back into the data work. It feeds back into how it is that we understand what the data means, how we should use the data. Is the data maybe showing us something that doesn't exist? Is it showing us something at a scale that's out of whack with reality? So really important, and this is kind of a big theme here, really important to think about outreach and data as in a very dynamic relationship.
Great. Thank you, Luke, for laying the foundation for me to get into the data itself. So this section is about understanding what piles of data you're likely sitting upon that are available to you and your partners to inform your outreach efforts and do all the things that Luke just described. So with that, we can turn to the next slide. So programs like yours don't have to rely on just one type of data. When you bring together health data, public safety data, social vulnerability data, you start to understand not just where things like overdoses are happening, but why they're happening and who is most at risk. So different data sources tell a different side of the story. So on this slide, we present example data sources that should be considered in your outreach efforts. This is by no means meant to be exhaustive, and you're going to hear and see other kinds of data sources as we progress through these slides. And I'm sure many of you are already using some of these, and you may have others you'd add to this slide. The goal today is to convey, really how best to use these kinds of sources to tell that complete story. And most importantly, how people with lived experience fill in what the numbers cannot, and what risk actually looks like day to day, and what builds trust, and what outreach needs to look like to truly work. With that, we can move to the next slide. So I wanted to share a four-step approach, if you will, to think about how to use data in effective outreach. First, most importantly, you have to start with a goal. Before diving into the data, it really helps to pause and ask, what are we actually trying to change? Not what data do we have, but what problem are we trying to solve? That might be something like reducing overdoses in a specific neighborhood. It might mean getting naloxone to people at highest risk, reaching people right after a jail release, or maybe it's responding quickly to a new fentanyl or xylazine trend. By being clear up front keeps the data focused on action, not just analysis. I'm sure many of you may have been in a analysis paralysis moment, right? Where you're overwhelmed by the amount of data and just need help understanding where to go next with it. So first, it's really important to start with that goal. Once the goal is clear, then ask, well, what data helps us get there? Again, there's no single data set that tells the whole story. So this is really usually about combining a few different sources. And the key is matching the data to the question you're trying to answer. So outreach is timely and intentional. As a third step, it's important to get practical about access to data. There is, and these are things like who owns the data, how often is it updated, what do you need in place to use it responsibly? Now, this part is probably not as exciting as other parts when I think about data, but it really does make a difference between thinking about data that you can actually use and data that just sits on a shelf. And lastly, making sense of the data together in community, which Luke has touched on, right? This is where lived experience really matters. Outreach staff, peers, people with lived experience who use drugs can explain patterns that numbers alone cannot. So when you combine data with real world context, you start to understand not just where risk shows up, but why and what kind of outreach is actually going to work. So this is the point where I feel data starts to really get exciting. With that, we can move to the next slide. So now I just want to introduce a really simple way to think about data. There's two buckets. We have active data and we have passive data. So I'm going to start with active data. And when I say active data, I'm talking about information that's being collected on purpose and in real time or close to it to really reflect what's happening right now. And this is the kind of data that's constantly changing and gives you a live picture of conditions on the ground. Active data usually has a few common things in common. It's ongoing or near real time. It often takes staff and systems to collect, and it's really responsive when things shift. Uh, the big upside of active data is it helps you catch emerging risks early. But that being said, it's not perfect, right? Active data can take more time and resources. Access can be limited. It's often pretty messy and incomplete, but even with these kinds of limitations, it's incredibly useful. At the end of the day, active data is best for answering the question, where should outreach be happening right now, and when does it matter most? On the next slide, we describe here passive data. And when we say passive data, we're talking about information that already exists. This is data that's collected on a set schedule, could be monthly, quarterly, annually, biannually, and often for reporting or admin reasons, but not necessarily for this day-to-day outreach decisions. So this kind of data tends to be more stable, it's more complete, it's validated, it's easier to compare over time. And because it's standardized, it's really helpful for stepping back and understanding the bigger picture. Things like overall trends, where the burden is highest, and how patterns are shifting over time. The trade-off is timing, of course. So passive data usually comes with a lag, which means you're not catching those emerging risks or deciding where to send outreach tomorrow. So I'd like to think of passive data as answering these big picture questions. How big is the problem? Who's most affected overall? And what patterns are we seeing over time? On the next slide, we just present some examples, again, not exhaustive, of the kinds of data that fall in each of these domains. So for example, on the active data side, we're talking about hotline calls or rapid community surveys, peer outreach notes, field reports. On the static or passive data side, we're talking about overdose death records, hospital discharge data, census or population data. Most programs, as I'm hoping you're reflecting on, are sitting on a mix of both of these. And so it's really not about choosing one over the other. It's really about understanding what each type of data is best at, and when using them together in a way that actually supports effective outreach on the ground. So with the next slide, we return to our case study. And here we show a visual of the County of San Diego's dashboard. And this gives us a very strong high-level snapshot of what's happening across the county. So you can see trends, counts, outcomes, and all of that absolutely matters. But at the same time, this is more of a passive view. It tells us what's already happened. It doesn't tell us why it's happening or how people are actually experiencing it on the ground. What's missing here is the voice of people with lived experience, people who are using drugs or the people who are on the front lines working most closely with them. And when we talk directly with people who have lived experience, we get insights that no dashboard can give us, things like barriers to service, gaps in harm reduction, what's working, what's not, and where there's opportunities to intervene earlier. Um, I think with that, I'd love to turn it back over to Luke to say, to add if there's anything else you'd want to share about your experience in the County of San Diego when thinking about this dashboard.
Yeah, thank you so much, Robin. And I think Robin's captured this really well. Like it's a really impressive dashboard reflecting all of these different vantages from which to look at kind of how the risk of drug harms are distributed across the community. But it is not an actionable thing. unless it's put in relationship with stuff that's happening on the ground. And so that is stuff that that we will address briefly in the next section. But I just want to highlight, like, that is the dynamic that Robin is pointing to is like the key thing. Got to figure out how to build this kind of thing, but then you've got to be thinking about how to build it in such a way that it is in kind of continual conversation with stuff that's happening on the ground. We're going to keep moving to a few considerations for outreach strategy that really sort of build on the points that Robin was just making, and this sort of like dynamic between what happens in the world of mostly like quantitative data generation and what's happening at the ground level. I want to, with the next slide, just sort of pause and note. I'm gathering that I'm, in this case, saying stuff that everybody is acutely aware of, that this work is part of the integrated planning effort. Again, right? We're talking in a way about it that I think feels very, very compelling because of the work. And so just want to, not because of a compliance requirement, just want to emphasize that in our, in our approach to it, I think we want to balance the utility of the fact that there's a compliance component here, that it's got to be included in your integrated plans, with what is really compelling about it, which is that it can make a huge difference in saving people's lives. So on the next slide, we kind of highlight some of what are the really important considerations in the relationship between the set of kind of metrics that Robin just showed, that dashboard, and their actual utility, right? So just some things that it's really important to acknowledge. Data is interpreted through local knowledge. Data does not mean anything outside the context of particular instances of data interpretation. And very often, social dynamics guide how outreach is delivered. And those social dynamics are very peculiar to the setting where work is happening. So really important to sort of think about, as you're building this, the relationship between particular context-specific social dynamics and how data are interpreted. Counties need to position themselves, again, with humility in this work. They should not be approaching this in heavy-handed ways. They should be approaching this with a sense of the importance of a kind of light touch, and with a sense of the importance of it being led by community rather than by government, where that's possible. Law enforcement is so incredibly important because the data infrastructure in law enforcement is so robust. Just think about HIDTA, high intensity drug trafficking area data, that's part of the DEA, right? These are complicated institutions that people have very strong feelings about, and that often make people feel not inclined to share information. Really important to understand that, to recognize the sort of liabilities for, I think, kind of community transparency when law enforcement is involved, but also to recognize the incredible utility of law enforcement driven data in informing how it is that we do outreach. And then again, and finally, it's really all about this dynamic between data quality and lived experience. How do we cultivate that relationship? So in the next slide, we begin to spell out some, I think, important kind of best practice considerations along those lines. We got to think about that relationship as living and as dynamic. So we need to structure how outreach teams will report what they're seeing on the ground back into the data infrastructure, back into the data analytic team. It can't be a unilateral relationship. It's got to be bilateral. It's even got to be multilateral, I would say. So, right, outreach teams need to be reporting back into sort of the teams overseeing data generation and data analytics. And it's really important to think about, as dashboards get built and that sort of thing, engaging with folks who are doing work closer to the ground as early as possible so that dashboards are best informed by lived experience. On the next slide, we emphasize taking it an additional step, right? Which is that you want outreach and kind of public health data infrastructure to be in conversation. Ideally, you would have broader sets of community members involved in the conversation. So where it's possible to bring additional stakeholders to the table, to engage with broader sets of community members about the kinds of things that they feel it's important be captured in data, be emphasized in data, that they feel data infrastructure traditionally associated with, with public health, with epidemiology, don't capture at all. So important to have those kinds of conversations informing how these kinds of capacities get built.
Okay. So here we talk about ways to bring different types of data together. As we mentioned, many of you are sitting on a lot of powerful data. It looks us through the chat. You're using both active and passive data, which is great to see. The challenge is never that there's not data. It's just that, or that we need brand new systems. It's really just about how do we make smarter connections between the data and the interpretation of that data. So the next slide, we're going to begin to share a little bit of how to do this. And since I see that many of you are using both passive and active, you are already bringing different types of data together. And I'm sure you each have your own lessons learned about how best to do this, the challenges that come with that, and the opportunities that come with that as well. So one practical way that we wanted to share today of bringing different types of data together is to layer data instead of fully merging it. Full data integration sounds really great in theory, but in reality, it's often very hard. You run into privacy issues, system limitations, timelines that just don't add up. So layering data allows you to still learn a lot without needing complex data sharing agreements or new infrastructure. So instead of trying to combine everything into one giant data set, you're just looking at different set sources side by side. I think we can move to the next slide. Um, Another really effective way of bringing data together, and we've touched on this a little bit already, is by pairing numbers with lived experience. So quantitative data is really great at showing patterns. It can tell you where something is happening and how often, but lived experience is what adds the context. It explains the why. And honestly, this is an area where a lot of counties already have really great insight, but may not be treating it like data. So, for example, that can look like treating peer notes, outreach debriefs, community feedback as real data inputs, not just anecdotes. Using the outreach teams and community members and what they're seeing on the ground to validate, question, and add nuance to what the numbers are showing. And bringing people with lived experience into the room when you're reviewing trends. So the interpretation isn't happening in a vacuum. We can move to the next slide. The third way to bring different types of data together is by using near real-term signals to fill the gaps left by lagging data. So a lot of the data we rely on, like mortality data and admin records, can lag by months. That's great for understanding long-term trends, but outreach decisions usually can't wait that long. Outreach needs timeliness. So instead of relying on death data alone, you all can supplement it with faster signals like EMS overdose responses or ED syndromic surveillance, drug checking alerts. The key really here is how we use the information and use them more as early warning signs that something is shifting. We move to the next slide. The last approach we want to share is really creating simple cross-system touchpoints. A lot of time data live in silos, public health over here, EMS over there, justice somewhere else, community partners in another lane. And bringing all that together into one system can feel very overwhelming and unrealistic. The good news is, again, we don't need full integration to make progress. Even small intentional points of connection can unlock a lot of value. So this might look like setting up regular cross-department check-ins where teams share what they're seeing. Could have a designated data point person or a liaison in which departments meet instead of building big integration teams. And it could also just mean simply agreeing on shared definitions for key concepts. So these kinds of touch points can really help teams stay aligned and coordinate better without needing new platforms, new systems, or any massive lift. If we move on to the next slide, and we've been touching on this all morning, we are proposing and talking about making a shift perhaps to a more public health perspective on data and how that is being used and can be used for effective outreach. Um, and again, it seems like many of you are already doing some of this, which is great. And on the next few slides, we'll show just some more examples of syndromic data, more public health data that might benefit you in informing effective outreach. Again, these slides, I'm not going to go through each one, but these slides are going to be available to you and can be a resource as you think about your inventory and how you best want to leverage data in your efforts. Same with the next slide. Um, and the following slide is just some more examples of data. And then really lastly, in the minutes I have, I think, remaining, so now, we've really been trying to emphasize the value of qualitative data, giving that lived experience voice, a real seat at the table, if you will. And one thing that we need to make sure is understood is that trying to collect this information in a meaningful way doesn't have to mean turning conversations into paperwork, right? It's not about just adding, it's really just about adding enough consistency to how you collect this voice so that those insights don't get lost. So one way to do that is having, a small set of core questions that everyone is generally working from, questions that line up with your outreach goals. Some teams are already, can use brief field note templates or debriefs, nothing complicated, and really just making sure that you're consistently collecting a few basics, like the date of the encounter, a general location, who the information came from, can really go a long way. And really the benefit of asking these core questions over time, you can start to see patterns, right, across different staff, locations, moments, while still leaving room for open-ended questions and responses. Um, and I think the last point I want to make before I move on is just to be really clear that qualitative data collection really needs to be low burdened, trauma informed, and non-punitive, and that this information is meant to support outreach and prevention, not enforcement and surveillance. Their goal really is to respect people's experience, capture what outreach teams are already hearing, and making that insight usable without adding necessary burden or risk. And on my last slide, just end with a little bit of a comic and a 6-step process on how we actually make use of and make sense of qualitative data. And that this process may, to some of you, feel mysterious or overly technical, but it really doesn't have to be. And the cartoon here is just one of my ways that I like to explain this process because it's honestly pretty accurate. And I think we're open to questions.
Thank you all so much for joining us today in our fourth part of our webinar series. Please remember, if you have any questions at all or need anything at all, we are here to support you. So please don't hesitate to email us at info@afbsstraining.org. You can also see it on the screen. Thank you so much for joining us again and have a wonderful, wonderful day.